Good afternoon, everyone. I think we can start. Thank you, everyone, for joining. We are very excited to be here today, where we are going to discuss ovarian cancer in Africa under the theme, The Neglected Women's Cancer. As you know, ovarian cancer is recognized as the highest leading cause of death among gynae cancers worldwide, and it is the second most common gynae cancer in developing countries. Ovarian cancer has a usually relatively poor prognosis, as you know, and it is disproportionately deadly because it lacks early detection or screening tests, implying that most cases are not diagnosed until they have reached later stages. Today, we have very distinguished speakers in our midst who are going to share their good work around improving outcomes in ovarian cancer. So this webinar is hosted by IOTIC Education and Training Committee, and I'm Susan Sadabwe. I'm a clinical oncologist at the Cancer Diseases Hospital in Zambia, interested in gynae cancer treatment. Our first speaker, thank you for joining, Verna, is Dr. Verna van der Puye. She's a consultant clinical oncologist at the National Cancer Center of Radiotherapy, Oncology and Nuclear Medicine at Kolebu Teaching Hospital in Accra, Ghana, and she has over 25 years experience. She has past, present leadership roles in IOTIC, ASCO, WHO, UICC, and ESMO, and she is an academic speaker at academic international cancer conferences, a co-editor and editorial board member and reviewer of several reputable cancer journals. She is also an external advisory board member of several D43 NIH grants. She is a recipient of the 2019 International Women Who Conquer Cancer Mentorship Award in the US. She serves as a co-chair at many Lancet commissions, including Women and Cancer Commission, and she is affiliated to the University of Ghana, sorry. I come from Zambia. Thank you very much, everyone, for joining. Verna, welcome.
Good afternoon, everyone. My name is Dr. Verna van der Puye. I'm a clinical oncologist at the Kolebu Teaching Hospital, and I'm presenting to you on current practice guidelines on the continent for managing ovarian cancer. This is just a brief slide talking about the histological types, and this was a study that was presented in 2021, showing that we expect an 86% increase in the number of ovarian cancer diagnosis, new cases on the continent compared to other countries, and also the fact that we have a high mortality incidence ratio. Unfortunately, it was only Nigeria that was studied in this trial, but it just shows you the difference compared to the Caribbean and the US. Also to show that in this study, Nigerians tend to present more with sex cord and germ cell tumors compared to other Caribbean blacks, US blacks, and US whites. And also to show that they tend to have non-serous adenocarcinoma types compared to other black women. Let's look at what happens in other countries. This was a study of cancer registries from 12 population-based registries presenting multiple regions, 11 regions, with over 5,000 women over the past 10 years. There were 13 deaths from 18,000 cases. As of 2020, we know that ovarian cancer constituted 2.2% of all the cancers, being the fourth most frequent in women, with 85% of them being epithelial, mostly with serous type. The median age at diagnosis was 50 years. Unfortunately, we can see from this slide that a lot of these women in the registry data had unspecified malignancy, so it wasn't classed properly according to histological stage, with countries like the Gambia, Congo, Brazzaville, and Zimbabwe, Harare, seem to have less incidence of diagnosis properly specified. But overall, you can see that there was a high incidence of epithelial cells and less in germ cells. Nigeria again seemed to have quite a bit of germ cell and sex cord tumors compared to the rest of us. But I'll say also that you can see that very few had diagnosis histologically. Again, like Middle Africa, Congo, Brazzaville, and other countries as well, mostly in the Western Africa. Countries, but most people are doing much better than they used to. Okay, some countries also had a high incidence of them being diagnosed on the death certificate as well, like we have in Uganda and other countries. So what are the prognostic factors? We know that overall outcomes for Africans are worse in terms of advanced presentation and overall survival. But some of the prognostic factors are being overweight, having a genetic predisposition, being detected early, having complete oncological surgery, receiving standard platinum-based systemic therapy. There's a study that actually showed that was recently presented, and even prior to the era of targeted therapy like PARP inhibitors and VEGF, we're able to have about 10-year overall survival in 20% of patients with advanced disease. So in spite of this, we can still do a lot. The next figure just shows you the overall survival 5 years in females diagnosed about a decade ago. And the only country that represented here is Algeria, and it just shows you that the survival is about 20%. But if you compare it to France, which is about almost 50%, overall ovarian cancer doesn't do too well. First of all, for Africa, why do we need treatment guidelines for ovarian cancer? From the previous slide, we are missing out a lot. I don't need to go over that again. Ovarian cancer tends to present with non-specific symptoms and with advanced presentation. There's very little data about how ovarian cancer is managed in Africa. We have improved access to diagnosis, but there's a limited improvement in the quality of care. We don't even have enough data to say whether we have improved quality or not. There was a systematic review of 32 papers showed improvement in outcomes with adherence to guidelines. Also, we know that there's a heterogeneity of histological subtypes, which are managed differently. And unfortunately, most of these recommendations, especially for advanced disease, are high resource dependent. What are the current guidelines available? We have the ones from high income and middle income countries. The Cancer Care Ontario, ASCO, ISMO with European Society of Gynecology, Royal College of Gynecology UK, the NCC and guidelines mainly from the United States regional and country-specific guidelines. Then we also have other resource stratified guidelines from ASCO, NCCN for Middle, East and North Africa, and then the NCCN for Sub-Saharan Africa and the National Cancer Grid of India. These are available online. Why do we talk about resource stratified guidelines? If you look at the bar charts, you can see this just shows data from Canada, where they looked at real-world treatment costs for ovarian cancer. There's over 2,500 patients. The higher cost was with the higher stage 3 and 4, over 100,000 per patient. And also interestingly, patients who were unstaged actually also had, it was quite expensive to manage them as well. And these costs were not realistic for low to middle income countries. Access is a big problem. And so we need to find out cultural sensitive ways of talking to our patients to diagnose them early. The common theme among all the guidelines were refer to areas with high expertise. What are the areas of controversy in resource stratified guidelines? I've been fortunate to sit in, a couple of them. And I think for me, the controversies were the diagnostic workup, whether to use just ultrasound or to use other modalities of imaging. But like I said, the information actually revolves quite fast. So at the time we're developing some of the guidelines, MRI and PET scan were not recommended for imaging. Maybe just a CT scan and CA125 in the ultrasound. And also FNAC and image guided biopsy were also not recommended. The extent of cyto reduction, that is the size of whatever is left behind. Optimal meaning should be less than 1 cm versus suboptimal when it's larger than that. But most of us know that on the continent, most of us tend to have more of a debulking situation where a lot of tumor is left behind. Laparoscopic surgery is controversial, so at this point in the guideline discussion, and people from high income countries tend to like to push it as an agenda. We also try and have to know the origin of the tumor, even though the management is the same, whether it's from the ovary, from the tube, or from the peritoneum. Lymphadenectomy is now recommended only for early stage versus for advanced stage. For early stage, the AURTC action trial confirmed that the patients did better. And for advanced stage, the LION study just showed that patients had more morbidities when you did a systematic lymphadenectomy versus just sampling. In terms of neoadjuvant chemotherapy, the data is not strong in terms of it being better than upfront surgery. However, we should know that in our continent where we don't have that much specialists, it's different to have proper, complete or optimal debulking in patients who have large ascites, liver metastasis, splenic mets, and lymph nodes. So it's best if these patients had neoadjuvant chemotherapy, but then some people tend to still prefer upfront surgery. Repeat cytoreduction when the patient gets upfront surgery, and because it's inadequate, they have chemo and then go back. A lot of studies that have shown that it doesn't make any difference, except for one from the EURTC that was a positive study, but overall, it is not recommended. For recurrent disease, again, we thought that going back to debulk was the best thing to do for patients with recurrent disease. But then the desktop over trial came out. There's also the eye model, which is more like a modeling program, and it showed that patients with good performance status, long disease-free survival, very low CA125, and very minimal ascites are those who benefited from this surgery. So you really have to be careful what kind of people you send for that. Genetic testing, again, in the high-income countries, recommended for all cases. It's quite difficult for us, but we can talk about genetic counseling. 3 versus 6 cycles of cisplatin for early stage disease. This was promoted many years ago by the European, mainly the British. There was a recent update in 2017 on randomized trial, which shows that 3 cycles could be equivalent to 6 cycles for early stage disease. Again, so many other trials could also support that, and even recently the GOG 157 as well. But however, this is not promoted in the United States. In terms of second-line treatments, a choice, there's a wide choice, and that was always controversy between high income and other regions. And in the use of bevacizumab, the endpoints were not really overall survival, except in only stage 4 disease in patients with ascites. It was more of a progression-free survival. So for us, it also became an issue in terms of the cost as well, and the cost-benefit ratio. Let's look at the ASCO ovarian guidelines, resource stratified guidelines. In terms of symptoms, they use more of the ultrasound. This was done about 2019, so it's a little bit older. And the ultrasound seemed to be the most important thing in diagnosis, in addition with the CA125. And then the use of MRI was not, very strong evidence. The evidence was weak, and it was only for enhanced setting, CT scan for limited and enhanced setting. In terms of metastatic workup, staging surgery, all patients actually should be referred. And no surgery should be done in the basic setting. Looking at the low risk stage 1 and 2, refer to the limited or the enhanced setting, and you could actually do fertility surgery. It was stage 1 or higher, refer to a higher level for proper surgery. You could still do fertility sparing surgery also in the enhanced, but the evidence was still weak. In terms of high risk stage 1 and 3, combination adjuvant therapy could be given in the limited setting, and if it was with stage 3 disease, you could actually also consider targeted therapy if you're in the enhanced setting, and the evidence was not that strong at that point in time. For neoadjuvant chemotherapy, up to 4 cycles, again, I've spoken about that. At that point in time, the evidence was not too strong. For patients who were metastatic after receiving surgery, stage 3 and 4, you could actually, after receiving chemotherapy, like in the neoadjuvant setting, interval debulking is not recommended in the basic, but in the limited, you could do surgery if there was some response or at least a stable disease, or else don't do anything and leave anything behind. For those who have had surgery for the adjuvant setting, if the patient has not had complete suboptimal staging, you need to go back and do more surgery and then give more treatment. Okay, and in terms of maintenance chemotherapy, it was only in the enhanced setting where you need to discuss maintenance therapies, the anti-angiogenesis, other targeted therapies. In terms of recurrent disease, surgery was only recommended for very small platinum-sensitive disease, where you complete the surgery. And for patients who've had previous surgery, chemotherapy, it didn't really change anything. It was best to do palliative care. You could also refer to a higher center, and for platinum-sensitive or platinum-resistant, you could get second-line treatments. And the other option was to give chemotherapy with or without targeted therapy. When they are resistant, you only give non-platinum single agent. Giving combination did not change anything with or without a targeted therapy. Let's look at the NCCN Sub-Saharan Africa. And what we did with this is just to highlight in blue what we want for our region, and then blot out what is really not available. So with this workup slide, what we added was that we needed regular gynecologists in here because we had more gynecologists than we had gynae oncology, and also that genetic testing was actually not available. So we blotted that out for most of Africa. In terms of optimal cytoreduction, again, refer out to the gynecologists, and then germline mutation was also blocked out. Now, when it came to primary post-surgery treatment, we realized that we blocked out a lot of targeted therapy and the use of genetic testing or genetic subtypes in their treatments completely from this guideline, and included the use of basic staging workup and follow-up workup like chest and abdominal ultrasound for surveillance. And so that's different from what we already had. In terms of the regimens as well, as you can see, in terms of stage 2 and stage 4, we blocked out anything that had targeted therapy because that was the access was poor in general, and most of the other basic chemotherapy were available. And in terms of for patients with recurrence, again, we blocked up a lot of the targeted therapies as well. Now, for patients with different types other than the mucinous, the other different types like the endometrioid, mucinous, and low-grade serous, mainly, I'm sorry. This is the slide for Middle East and North Africa, and just to show you, this is for patients with primary stage 2 to 4 and low grade. You can see that not very little was, in fact, nothing was blocked up, just to say that bevacizumab was only for stage 3 and stage 4 disease. And in terms of the workup for recurrence, PET scan, MRI, CT were all recommended compared to what we had in the sub-Saharan Africa. Again, let's look at the national grid of India. It looked at early stage, they did CT scan and MRI was recommended just to differentiate between benign and malignant disease. For locally advanced, staging laparoscopy was recommended, and the PET scan only for recurrent disease. It might help with the staging. And also interventional radiology, they recommended image-guided biopsy, which was not recommended in the other guidelines, and also genetic counseling only for high-grade serous. All right, surgery was almost identical. For adjuvant chemotherapy, they recommended 3 to 6 cycles of carboplatin, but for high-grade serous, recommended 6 cycles or 6 cycles of carboplatin. For surgery, interval cytoreduction after 3 cycles of neoadjuvant, and they agreed that the outcomes were similar versus upfront surgery, but then it limited surgical mobility when you use that. In terms of chemotherapy, because patients might need more surgery, under these settings, chemotherapy was to do with 6 cycles of carbo, and they actually went up to 8 cycles, which may have not been shown to show anything. The patients with poor performance and comorbidities were to have carboplatin only, and the use of intraperitoneal chemotherapy and targeted therapy was optional, and you need to discuss that with the patient. Same with recurrent disease, they recommended chemotherapy based on whether it's platinum sensitive or not. For platinum resistant, they only had very few options, and the use of bevacizumab or targeted therapy. And then for cytoreduction, only those with low-grade disease were recommended. Again, the difference here is the use of radiotherapy for oligometastatic disease, and they also included GEMS in their treatment. So in conclusion, there are several guidelines existing for ovarian cancer. The limitations are diagnosis, surgical techniques, and drugs. Multidisciplinary care is key in areas with limited specialization. Patient preference should be high on the agenda. You need to discuss all options with the patient. Be realistic about the outcomes, even in current therapies. Consider the management of toxicities, compliance, and the health system strengths. Review guidelines as evidence is rapidly evolving. Critically appraise new evidence in the context of resources, and be fair to the patient and refer to specialized areas. I also like to talk about 2 cases that I would have liked to present. One is a a 57-year-old who presented 3 years ago with metastatic, not low volume disease, high volume disease, metastatic mucinous carcinoma of the ovary. Because she had a poor performance status, we gave her 6 cycles of carboplatin. 3 years later, she has recurred. She still has low performance, the performance status is quite low, and we are reconsidering carboplatin. But in other settings, would you add targeted therapies? We don't do routinely the genetic testing yet to see whether she could benefit from PAP, because most of them cannot afford it, or just pure palliative care. Now, we also have a second case who's about 75, who was diagnosed 3 years ago with stage 3C ovarian cancer. She received carbotaxol for 6 cycles. She said she couldn't afford Avastin then. And then a year later, she recurred again. She was platinum sensitive, so we challenged her with gem and cisplatin. And another year, she recurred again, and this time she agreed to have bevacizumab. She's completed 6 cycles, which is 4 months. Her CA-125 has dropped drastically. She has a good performance status, and we are discussing further continuation with bevacizumab. The problem is that it's almost difficult for her to complete 2 years or even 1 year of bevacizumab. So we are trying to complete 6 months. I don't know how far that would go. So what would be your recommendation, with that? Thank you very much for listening.
Hi,
that concludes my, yes, thank you.
Thank you very much, Werner, for the wonderful presentation. Any questions from the audience? I was thinking that we could move to the next presentation, and then maybe questions could be tackled to both you and Rahel at the same time, in the interest of time, since you were both talking about guidelines. So we'll move on to the next presentation, Rahel. Just give me one moment. Rahel is here. So Dr. Rahel Gerber is a professor at the University of Minnesota with a clinical practice that spans surgical and medical management of women diagnosed with gynae malignancies. She completed her medical degree at the University of Michigan and Masters of Public Health at Johns Hopkins School of Public Health. Her academic work is focused on improving cancer care for all women with gynae cancers by increasing access to quality care and clinical trials domestically and internationally, cervical cancer prevention, as well as global gynecology surgical training. She is the current Associate Director on Diversity, Equity, and Inclusion at the Masonic Cancer Center, University of Minnesota. And for her contribution to gynae oncology, global education, and curriculum development, she actually received the International Gynae Oncology Society 2020 Award for Excellence in Teaching. She currently serves as the international mentor for IGCS Gynae Oncology Fellowship Training in Ethiopia and Rwanda, and she serves as a chair for the Gynae Oncology Special Interest Group under the African Organization for Research and Training in Cancer IOTIC. She is a panel member of the NCCN Guidelines Committee for Sub-Saharan Africa, and as well as a member of the African Cancer Coalition, an initiative supported by the American Cancer Society. She is a co-author of the ASCO Resource Stratified Guidelines on Ovarian Cancer that was published in 2021. Dr. Rahel Gerber, you're welcome.
Thank you very much. It is an absolute pleasure to be here with all of you. And what we'll be talking about in the next few minutes, I suppose, is really about the implementation of guidelines, more specifically here about ovarian cancer guidelines. And my purpose really is to make an argument as to why implementation of guidelines is good practice. Discuss with you briefly about the process that have proven to be effective for improving the adherence to guidelines. And ultimately, implementation of guidelines is a local process. It cannot be prescribed since the factors that influence implementation can vary based on the setting. So what I would like to do is also open up the conversation in terms of what are the successes and challenges that each of you might be encountering in your own local settings, in the hopes that we can collectively learn from each other. So the first point that I want to make in terms of why should we do implementation of guidelines, it's really about outcome. Each of us comes to work ultimately to improve the survival outcome for women with ovarian cancer. And guidelines are one of the tools through which we can actually impact outcome. As most scientists, you'll want to know the numbers, how much, what percentage, to what extent, how many more months. And what I'd like to redirect you is the process under which the guidelines are actually developed. Verna and I had a deep understanding and experience over many months working together in developing and ultimately a publication of the ASCO Resource Stratified Guideline for Ovarian Cancer. And what I can assure you is that it is an extensive review of the best and most highly conducted research in ovarian cancer. The process involves stratifying based on the quality of the study, a consensus that's derived from experts that preferentially leans towards utilizing evidence data. And when there's no evidence data, then judicially talking about what is the current practice guidelines. So by the time the guidelines arrive at your desk, they have gone through the process in which thousands of women participated in clinical trials. Evidence was assessed and analyzed, published, digested, and ultimately, to the extent possible, experts have looked at it and tried to come up with an algorithm that can then be applied to patient care. So fundamentally, it makes sense that when guidelines are used in the actual treatment of patients, all they're doing really is translating the scientific knowledge, the most up-to-date scientific knowledge, to treatment protocols that can then be applied. So it is not far to conclude that by using treatment guidelines, such as the ovarian cancer guidelines, depending on which international society, they often follow each other in terms of the guideline protocols, that ultimately you're working to improve the patient's outcome. So that's sort of the why. So if you can buy into the why, what ultimately is the issue really is about the implementation, which is the process. What are the challenges that you might be encountering in your local setting? So the first process that was developed and through investment of multiple partners is working to adapt international guidelines that were really done thinking about patients in the high resource setting, but now we have to face the reality, we're talking about our local settings. And colleagues within the Africa, when they looked at adapting the NCCN guidelines, quickly realized that there is, even within the region, great variation of resources. And so it is very likely that there is even more need to adapt the guidelines to country-specific resources. And some Ministry of Health, depending on how the healthcare is organized and funded in the country level, they then work on adapting the guidelines, and you might find that some treatment options are no longer available depending on resources. So that would, of course, require you to actually look at country-specific guidelines. Additionally, it's possible that it's not really a limitation of material resources, but it's much more of a human resources, meaning you don't have the specialist to be able to deliver highly complex surgical procedures, for example, in the setting of high volume advanced ovarian cancer. That requires a very highly specialized gynecologic oncologist. So it's possible what we're looking at is not that we don't believe that the guidelines are best process to improve quality for patients, but that we either lack the material or the human resources to be able to effectively implement them in our own setting. The first one, in terms of material shortcomings, I obviously am in no position to make a comment upon that, but I can speak to you about the human resources. That's, I think, an area where collectively we've been working and should continue to work on that. So what we're talking about is taking someone who is a general, either a general OBGYN or a general internal medicine, and what is the process to make them specialized so that they are equipped with the skills to deliver oncology care. And that's a subspecialty training. There's no doubt that subspecialty training is really the most effective way in which we can improve the outcomes. Training in the Fellowship of Gynecologic Oncology ultimately is a process of or a tool that would enhance our ability to actually improve the implementation. Through the course of training and what we've done in any of the settings in which I've been involved in the teaching is that the guidelines themselves are used consistently through the course of training. After all, they're nothing more than a synthesis of the scientific data. And so the fellows themselves learn, and the practice of using the guidelines becomes part of their daily work pattern. So I think if you are at all involved in the training of fellows, if currently you're not consistently using the guidelines, I would urge you to work with them and have them refer to guidelines so that it becomes part of their practice and usual way of doing patient care. Now, every fellow will tell you they're very busy. There's no fellow that is not busy. And so they're so busy that they don't have time to go back to the actual material to look at the specific guidelines, or better yet, based on the guidelines, to then look at the original research to see what was the evidence that supported the recommendation. But fellowship really is about learning. So we have to make the time for them to pause, reflect on what the data shows, synthesize it, and then report it. And that's really ultimately the benefit of going through a fellowship training, is not only the doing of patient care, but the learning and learning how to learn. So that is, I think, one of the ways in which I found implementation of guidelines to be most effective and long lasting. And so I use that consistently in my learning for my trainees wherever I go. The next part that I want to talk about is what the data has shown in terms of current implementation of guidelines, the limited studies that we have in sub-Saharan Africa. Our colleagues at the University of Lagos actually looked at who is using breast cancer guidelines, and most often people were referring to the NCCN guidelines, sometimes to the harmonized NCCN guidelines, but to the NCCN guidelines. 92% of the 109 individuals who were surveyed said that they did refer to the guidelines. Now, what we don't know is, do they refer to it once a year or consistently with every patient or weekly during tumor boards? So the actual detail is not available, but at least we know that majority of them are aware of the existence of guidelines and are using them and incorporating them into their treatment planning at some point. On the counter side, there was a paper published led by Dr. Eva Kentelhard out of Germany, and they did a retrospective review of 9 countries. 3 of them were in East Africa, I believe Kenya, Uganda, and Ethiopia were among them. And they looked at the adherence to guidelines, so the treatment, sort of curative treatment for cervical cancer patients across 9 countries. There's many, of course, challenges with doing retrospective reviews. So no doubt about it, that there could always be improvement. So what they found is that 1 out of 6 patients were being treated with curative intent, meaning with the intent to ultimately receive the full pathway of the treatment guidelines. That's a low number of adherence for a cancer that's very common among our gynecologic cancers in the area. So on one end, we realized that likely most, if not all, oncologists are in some way utilizing guidelines across sub-Saharan Africa, but we're not aware exactly how it's impacting patient outcome, nor are we aware to the extent in which it is consistently and effectively being used. That's a room for more research in that area, and hopefully Aortic and colleagues here would be able to participate in that. What we do know are that there are some specific areas of challenges in adapting ovarian cancer guidelines, and other literature done in high-income countries has actually shown that. One is in the surgical. So are all patients being offered surgical management for their ovarian cancer. That's one area of challenge. The next is, are we consistently defining optimal tumor cytoreduction? And if so, is that being applied and documented correctly? So what I call optimal tumor cytoreduction in my institution, is that what Verna calls at her institution? Is that what Khadija calls at her institution? So these are sort of needs for consistency, and they're best done when there's, of course, a group assessment in terms of what's optimal. The third part is how neoadjuvant chemotherapy is being used, and is it reflecting what is actually known about the use of neoadjuvant chemotherapy in the literature. And certainly, I think that's one area, at least from my experience in sub-Saharan Africa, there is a great deal of variation of how neoadjuvant chemotherapy is being applied. And likely that speaks to the shortness in terms of surgical workforce. So ideally, as we have increasing number of highly trained gynecologic oncologists who can deliver surgical interventions, then we will begin the process of treatment algorithm with surgery first. No doubt about it, some patients will always require neoadjuvant chemotherapy, but a majority of ovarian cancer patients should really be treated with surgery upfront when feasible. There are some factors that appear to be positive influencers of implementation and adherence of guidelines. One is having a cancer center, as you all know, where there's high volume of oncology cases, and you have practitioners who do high volume of specific cancer subtypes. So gynecologic oncologists obviously are very subspecialized and do many ovarian cancer, but in some setting, it's a medical oncologist who do that role. And as much as possible, if you have a person, an oncologist in this case, who does high volume of a specific cancer, they're much more likely to be using and implementing guidelines consistently in all their patients. So I think we can also discuss about, is there space and is the time come for more and more subspecialization in specific cancer subtypes? No doubt about it, in some setting, this is yet not feasible. What we can do in the meantime is to improve the utilization and the quality of tumor boards. Tumor boards are the most effective process to actually do implementation because they force us to stop, discuss the patient, reach a consensus, and make a recommendation. Tumor boards also provide us a way after, let's say, a 6 months, 12 months timeline to do that retrospective reflection to say, over the last 12 months, we've treated X number of patients, provided, X number of surgical interventions, X number of first-line chemotherapy, X number of second-line. Where are we lacking? Where are we seeing the challenges? And then collectively develop quality improvement projects. So most likely all of you who are obviously very passionate about ovarian cancer are currently doing that. But if you touch upon others who might perhaps not be involved or participating in tumor boards, I know how challenging it can be to keep on schedule on tumor boards, but nevertheless, the literature shows it is the most effective way for us to make improvements in quality outcomes. So I'd like to open up the conversation for the remaining, it looks like 15 minutes we have in this discussion, and maybe give it back to the moderator in terms of how we should move forward. And the question that I have really is, what are successes and challenges you're experiencing in implementation of guidelines? Thank you very much for your attention.
Thank you very much, Rahel, for that wonderful overview of implementation of guidelines in our setting. Anybody would like to make a comment? There's no question in the chat box, but you are free to unmute and voice out. Anybody wants to comment?
I would just like to say, this is Dr. Van der Poel, that we do have a wide spectrum of patients. Some patients can really afford these advanced treatments in your settings. So I think you still have that discussion. That's why I always say to discuss all options with patients. I think we shouldn't assume. So, and you also have to be truthful about the duration, expected duration of treatment and the side effects. I think that has to be a frank discussion, you know.
So I understand, Vernon, you're quite correct. One of the lessons we're learning, especially in our work within health equity, is that we never know what the patient is capable of, you know, that we, as you said, our responsibility is to offer the most effective and the most available treatment options. We can never know. Sometimes I'm very surprised at the resources patients are able to put together. I'm also very surprised at their ability to be compliant when I might have doubted their ability to be compliant. So that is the challenge to us, of course, is to try to carry every patient through the full course of treatment, knowing that for many it can be very challenging. But when possible, we certainly want them to have the best treatment options. But you are absolutely correct about the challenges.
Thank you very much for that response, Rahel. Verna, I also wanted to ask with regards to, you talked about in the NCCN guidelines that some things were dropped. What did you mean exactly by that?
So
on
the parent,
know.
Yes, on the parent guideline, they had germline mutation screening, germline screening for the patients, and they had a lot of bevacizumab and then PARP inhibitors. And that was not available to most of the African countries. So that was whited out. Doesn't mean that you shouldn't do it, but if you do it, if you have access. And then where it said refer to gyne-oncologists, emphatically, we added gynecologists because most of us didn't have that many gyne-oncologists. Those were the main differences. And like I said, if you compare it to the MENA region where they had a lot more resources, they didn't really block out anything, just to show you the differences in resource and how to appropriate them to the patients that you have.
Thank you. Apparently, I've just been informed that we can't unmute for those who are muted. So please make sure you post your comments in the chat box. Let's not lose this opportunity. Maybe I'll ask someone to comment. There's a patient that Dr. Verna was discussing, and she asked for a comment. Anybody wants to respond to that?
One of the questions is that do you do maintenance targeted therapy, let's say bevacizumab, in your patients with locally advanced disease in anywhere in Africa, apart from MENA region, of course? Does anybody do that?
For us, hardly. Maybe we've had a few patients, but most of the time they have to get it on their own. It's not funded through the public system, but occasionally when the patient is able to afford, then yes, the patient will be offered. But this is rather not the norm. The norm is where we just give a standard chemotherapy. Khalid had a comment. Please go ahead, Khalid.
Thank you so much for the great presentations. I'm Khalid from Morocco, and I'm the next presenter. So regarding your question, Verna, in fact, in Morocco, we don't have maintenance, unfortunately, for patients. We don't have PARP inhibitors, and bevacizumab suffers from drug shortage. So I think we share similar concerns between North and all other African countries. So again, yeah, we don't have any PARP inhibition available in the public sector. It's only available in the private hospitals. And for bevacizumab, we use it in some cases in frontline treatment and also in recurrent disease. But as a maintenance, unfortunately, we don't have any options available. Thank you.
Thank you, Khalid, for that input. I also wanted to just reiterate what Rahel said with regards to implementation of guidelines. I've found that the easiest way to implement guidelines is through your training, where you use them in the teaching and the trainees know that that's what we use to teach, and exam questions will come from the guidelines. And also tumor boards I found are very helpful in implementing guidelines. Thank you. There's a question from Olutosin that currently he has 2 patients in Ibadan, Nigeria on bevacizumab. Thank you for that input. I know, Khadija, you kind of work in the private sector in Kenya. Do you want to give us an overview of maintenance therapy in your setting?
Good afternoon, everyone. Susan, despite the private setup, it's very expensive and patients can't afford it, unfortunately.
It looks like we share a common problem, which I think we need to
Yes.
publish.
Yes,
it's
it
not
looks
that-
like it's actually much more common than I thought. I thought
Yes.
that maybe other centers like Morocco might have, but looks like it's actually more common than we thought. Khadija, maybe, yes, please go ahead.
Yes, so Richard, do you think you can help us out? How much addition does the maintenance bevacizumab add, considering that we have really heavy cost-effective problems in terms of toxicity? Really, should we strive? Should the patient sell their houses for a stage or
And the
cervical
answer is
cancer?
do not sell your house, right? Because we know that even with the addition of maintenance therapy, that a majority of those patients will have recurrent disease after discontinuing. So putting all your money into that maintenance likely will not be curative. Often it delays the time to recurrence. Now, that's not this case with PARP inhibitors, right? So PARP inhibitors, when we have the capacity to have that discussion, particularly for patients who are BRCA1 or 2 positive, that is a life-saving measure. That might be when you want to sell your house, but I'm not at all, I don't want the people who sell bevacizumab to find me. I'm going to have to go into hiding. But nevertheless, the reality is it's a very expensive drug. It also requires high level of monitoring, so that frequent visits, checking for toxicity itself can be very burdensome. So I, at least from my own personal recommendation, is that is not where we should be putting in all of our funds at the moment.
Hi, Rahel again. I have a question, of course, if you want. In fact, to treat ovarian cancer, we need good surgeons. Unfortunately, in Morocco, we do surgery by general surgeons and obstetricians. So we don't have any gynecologic oncology as a subspecialty, unfortunately. I think it's the case in all African countries. My question is about how can we develop more subspecialties in cancer surgery in Africa with what we have available in our hands in the training process. Can we talk about, I don't know, maybe collaboration for fellowships, so we can send our young residents or also general surgeons to do fellowships? And how can we really go further and implement gynecologic oncology as a specialty, an independent specialty in low-income setting?
Well,
Thank you.
Kali,
Yeah, Rahel, please go ahead.
yeah, I was saying it's almost like I prepared Kali to ask me the perfect question about developing Gyn Oncology Fellowship. The time is perfect. The time is right. So what you probably may have not heard is that through our International Gynecologic Cancer Society, we are implementing Gyn Oncology Fellowship programs, usually 2 years, in some settings 3 years. Countries like Kenya, Uganda, Ethiopia, Rwanda, I believe Nigeria has 5 programs that are either in implementation or up and coming. Ghana has had its own fellowship program through some international other partnerships. Obviously, South Africa has highly established programs. So you have regional partners who are skilled, who can help you in that process. We can help you connect to international organizations. The field itself has advanced drastically when we've had gynecologists who've been very much focused on that disease. So I completely agree with you, and we want to support you. Please reach out to me directly.
Thank you very much, everyone, for your very important comments and interest. We have a few comments in the chat box from Francis Reed, who's going to give us a talk later on. Many stories coming out of the Every Woman study in basic treatments, delaying treatment till they can sell some land, sell some animals, and issues with health insurance, especially when husbands leave their partners, they even lose cover. From Olotosine, that we need to overcome the challenges of genetic mutation in sub-Saharan Africa before PARP. Maybe Rahel, you can give a quick comment on that one later, just now after I finish reading through the comments. And then Christopher Williams, thank you for joining. I saw earlier on it's 5:15 a.m. in your place. Thank you for that comment. And Vernaya, I agree, things are coming down. Hopefully they'll come back down quicker rather than later. Rahel, do you want to take that question on the issues of genetic mutation, and maybe Verna actually, before PAP?
I think generally we have to test. This is one biomarker that you can't get around. So the problem is mainly with access, and I think it's getting cheaper. And definitely I have 1 or 2 patients who are on maintenance PAP and are doing, even when they decide to stop, you know how Africans were, they decide to stop their treatment, they stop for 6 months, they restart, and things start going down. I think this is a wonder drug for us, but we need to find out how many people are testing, how many people can afford the medication, and maybe come out with some recommendations for essential medical lists. I think it's something to talk about.
Thank you very much. I think we'll move to the next speaker now. Our next speaker is going to talk about how ovarian cancer research in Morocco and how individual initiatives change the neglected cancer landscape in Africa. Khalid El-Bari, correct me if I haven't pronounced your name correctly, is a primary investigator of the Ovarian studies and the founder of the Cancer Biomarkers Working Group. He is, apologies for that. And he has published many peer-reviewed articles in the field, can you hear me? In the field of predictive and prognostic cancer biomarkers to improve survival. His research focuses particularly on biomarkers for digestive and gynae cancers, such as ovarian and colorectal malignancies. And he's currently a member of various organizations, ESMO, ASCO, ESGO, and he's an editor and reviewer for a lot of journals. And he is also interested in teaching evidence-based medicine, clinical research methods, and publishing to medical and PhD students. Welcome, Khalid. Looking forward.
For this opportunity to discuss this aggressive women cancer and to bring all African researchers together so we can go ahead and make more progress in this field. In this perspective, I would like to thank Dr. Nazik Hamad for bringing all African researchers today so we can discuss ideas and projects and maybe some further collaborations. So my talk today is recorded, and I will be very happy to take all questions during online meeting. Is gonna talk about ovarian cancer research in Morocco based on my humble experience in this perspective. First, I have no conflicts of interest to declare. And if you want to have a look about where I do live and where I do research on ovarian cancer, in fact, it's a city called Oujda, and it is located in the northeast region of Morocco. And I think the best thing to start with during this presentation is this. In fact, you do know that high-income countries really do not care about our issues. So we need to resolve our problems ourselves and do research to improve our patient care. I think the best way is to develop clinical and translational research that is affordable for our under-resourced setting and that can change our daily practice in LMICs, which is a thing that is really urgently needed. Before taking ovarian cancer as my research topic, in fact, I conducted a bibliometric analysis to see what has been done about ovarian cancer in Morocco. And I demonstrated based on this bibliometric research that nothing is there. So it's a neglected cancer. And as you can see here in my slides, most of research that was published on ovarian cancer was dominated by case reports. And there are only few original studies and reviews on ovarian cancer the day I started to work about ovarian cancer. And when checking those original studies, I discovered that they really don't contain any patients with ovarian cancer, but they were all breast cancer patients. And of course, the number of publications as compared to our friends from Africa was very low. So this was a very important motivation for me. So I took it as a research topic to improve this field in our setting and to provide more research on ovarian cancer with what I had in my hands. Also, I found that regarding gender disparities, female scientists were mainly first authors, but rarely as leading principal investigators. And of course, most of our research on ovarian cancer in Morocco was published in French, and this was maybe one of the limitations of our international visibility in this field of gynecologic oncology. So this was my rationale. To be honest, when I did this, I didn't really feel good because there was nothing really about ovarian cancer. And I said to myself, maybe this is a good opportunity to go further and explore this ovarian cancer neglect in Morocco and provide more research on this topic. So, my first conclusion was that ovarian cancer was really a forgotten woman cancer in our country. So a project called Ova Nord-Est. Ova Nord-Est, in fact, means in French ovarian cancer in the northeast region of Morocco, and it has 3 aims or 3 periods. In fact, the first study is Ova Nord-Est 1, which is a real-world study to explore epidemiology, clinical and pathological characteristics, survival outcomes, and our real-world practice of ovarian cancer care in our setting, and also to provide more training of the oncology workforce so they can conduct more research on ovarian cancer, and also to build on a cancer biomarkers working group so we can go further and explore some biomarkers available in our setting and see if this can be improve stratification of our patients and predict survival. Also, one of the aims of the first step of our project was that we need to have some expertise in the field, so we need to publish more meta-research in this field, particularly books and special issues with international journals, and also to tackle gender inequality in our practice by giving more chances to our colleagues, females in the department, so they can publish more in this field. And the second step was a prospective study, and it is not yet done. It will start this year, and it will prospectively collect data for research purposes. And also, we are going to build a Moroccan Society for Ovarian Cancer and also organize awards for our young oncologists in Morocco. And the last step is something big. It's my vision. I really dream to build a Moroccan Institute of Ovarian Cancer and also conduct some clinical trials on this aggressive cancer in Morocco. My vision was published in Gynecological Oncology Reports, where I described what I can do to improve this field in Morocco, and all the objectives of our project were published in this commentary perspective that you can find online and open access. And in fact, my idea was that I could develop a prognostic score that is available and also adapted to low-income setting that will contain some biomarkers based on blood count and it is something that is available for all low-income setting. So the OVA Nordest-1 study was an exploratory cohort to collect data retrospectively and build a registry on ovarian cancer, and also to collect some biomarkers based on blood count to explore their value as predictive and prognostic biomarkers for ovarian cancer. And of course, the second step is to validate this based on a training and a validation set, which is the second step of my project. Before doing so, I published 2 reviews about all biomarkers that can be used to predict outcomes in ovarian cancer. So this provided me with the rationale to select the best and affordable biomarkers for this purpose. So when reading the cancer hallmarks, as you already did maybe, you will realize that inflammation, for example, is a hallmark of cancer, and it can be studied easily based on blood count using ratios of circulating human cells. As you can see here, for example, lymphocyte to monocyte ratio, which is widely studied in various settings, and it demonstrated very interesting results regarding prediction of survival and also resistance to treatment. So I selected these 3 biomarkers, and I appraised them based on a systematic reviews to see if there is evidence supporting my my rationale. So I included 17 meta-analyses. I priced them using the AMSTAR2 based evidence synthesis method to see the quality of the current. And also I used the grad approach. I found some very interesting evidence to support the use of these biomarkers to develop a prognostic score for ovarian cancer patients. So our real-world ovarian Nordest-1 study is highlighted here. It's a retrospective study with more than 200 patients, mainly advanced cancer, and with a median follow-up of around 50 months. And these patients were treated in our cancer center, which is the only available cancer hospital in our northeast region of Morocco. And also, as you can see here, I was surprised when I found that only 1 patient in our study population had the BRCA status, and she was really very lucky. And of course, in our practice, we don't have any PARP inhibitors available for maintenance therapy. Here are the median overall survival of the study population. As you can see here, is 32 months, which is similar to some similar setting in low and middle-income countries. And as you can also see here, platinum-resistant disease had reduced overall survival as compared to platinum-sensitive disease. And of course, the debulking status is a prognostic factor, as you know, in ovarian cancer. And this was also confirmed in our real-world study. And for patients who had R0 debulking had the best survival odds, hazards. So this is just an overview of our study. So I selected 3 biomarkers based on our database of OVA Nordest-1 study, and checked if these biomarkers can predict survival. And as you can see here, the neutrophil to lymphocyte ratio was associated with overall survival, and patients with a high ratio had reduced overall survival as compared to those with low value of this biomarker. Similar thing was noticed for lymphocyte to monocyte and also for platelet to lymphocyte ratio. So all of these 3 biomarkers were important, and they demonstrated some value in predicting overall survival and also progression-free survival. When combining these biomarkers in a composite biomarker, we also demonstrated, for example, here that the pan-human inflammation biomarker is also predictive of overall survival in ovarian cancer patients. The thing here is that it's something based on blood count. A blood count at baseline is available for all low-income setting, and it is something that we can use to study immunity, peripheral immunity in ovarian cancer patients, and to see if they can predict, if this can predict survival outcomes. And as you can see here, the composite biomarker was also predictive of overall survival. To go further in this project, I published a book on ovarian cancer biomarkers to have more expertise in this field. So I was very lucky when that we did some progress in this particular field, which was really neglected in Morocco. We published a book on ovarian cancer and also two special issues with seminars in cancer biology and current direct targets on platinum-resistant ovarian. And really, when I saw that my books were printed, then it was really something very motivating. So I said to myself, okay, this is good, and I need to go further and do more. In fact, when seeing a special issue, for example, on platinum-resistant ovarian cancer, you will realize that we published reviews and critical reviews about emerging topics, such as, for example, the novel origins of ovarian cancer, the importance of antibody drug conjugates for ovarian cancer, for example, in platinum-resistant and this approach of using biomarkers for under-resourced setting, which are affordable and available in all low-income setting to do research on ovarian cancer, was published as a vision with the ASCO. So if you want to take a look about all of this, just have a look at the ASCO connection, where you will find all the details of my vision to develop prognostic scores and biomarkers in low-income setting with what is available in our hands. This is also published with eCancer website. So if you want to take a look about our project, just go there and you will find more details. And I will be very happy to take some questions at the end about this project. Also, to provide more guidance for oncologists working in low-income setting to do research in oncology, particularly on ovarian cancer, we published with GCO Global Oncology this guide of methodology, so they can use what they have in hand to develop more research on aggressive cancers in their setting. When I saw that we were well classified as young researchers based on the ExpertScape website, I was really very happy because we did great. Now we are, I was one of the most famous young scientists working ovarian cancer in Africa, and this was really very motivating. The second part of our project was about tackling gender inequity. As I said, in our bibliometric study, we demonstrated that females were not well represented in publication on ovarian cancer. So one of the aims of our project was also to tackle this and provide some solutions. And this is in line with this famous bibliometric study published by my colleague, Dr. Mariam Motibi, who demonstrated that in Morocco, for example, here, females are not really well represented in oncology publications as compared to males. And I think this is something similar to all African cities. And of course, when you have more females in your team, you have more, you have a greater chances to have performance research. So one of the aims of my project was to give more chances to women to conduct research on ovarian. And one of the examples here that illustrates my vision is that I gave the whole database of my ovarian to young residents in medical oncology, so they can publish from there on ovarian. And here, this is Dr. Ikram Kharmash, which is a resident with us in our Department of Medical Oncology, who presented some data from our database. So she had access to this database, so she can publish from there. And it was based on our mentorship, so we can help young female scientists to publish and go further in their projects on ovarian cancer. And she demonstrated that systemic, for example, systemic inflammation index was predictive of survival, and she did great when she wrote the paper, and now it is under review. So it was just based on our idea. We shared the database of our ovarian study with female scientists, and then they could publish with our mentorship and supervision. And of course, I think when bringing together the field of ovarian cancer and gender inequity, I think it's a good thing. Ovarian cancer is a neglected cancer. Women are neglected, so giving them the chance to work on ovarian cancer is a good idea. And also, I was very highly involved in providing training for young scientists in our setting to do research on cancer, because if you want to do research on ovarian cancer, you need to train young residents and oncologists to have the best standards in the field of methodology, so they can go forward. I was very happy when in fact, I put this as one of my my main objectives for my research and also for my project. And during this, I provided seminars, training workshops, and mentorship for our medical doctors and PhD students, so they can do great in the field of ovarian cancer. And of course, I also tried to study some research integrity issues in the field, because we cannot really progress in the field of ovarian cancer without preventing issues related to cancer research, like here, for example, predatory publishing in oncology. And we demonstrated that some of the research from African scientists are published in predatory journals, and this is not acceptable. We need to publish our data from our patients in good journals, and I think the best way is to do research on this field of research integrity and share our vision. In this perspective, we diagnosed the problem. We know that African scientists and also Moroccan scientists publish in predatory journals, and we provided training on research integrity based on distance education, French, also in English for our Moroccan institutions, and also for some of our colleagues in Africa based on the CMRA initiative. So this experience in preventing our research to be published in predatory journals using distance education allowed us to publish this experience in an international journal for research of educational integrity, where we described our experience in tackling this issue. And of course, I explored more research integrity issues in our setting. For example, here, plagiarism. And I was very happy when I see that my colleagues now are not doing really plagiarism. They know how to write, how to criticize literature, how to apprise the evidence, and then they can do accurate research. So this year, I was very happy when I declared that the first study of Nordest 1 was declared done. So all the objectives of our Nordest 1 study are here, and I could alone respond to this urgent need to have the Nordest 1 study about real-world practice of ovarian cancer care, about training young oncology workforce, publishing books, developing the cancer biomarkers working group, tackling gender inequity. So now, starting from this year, this is Nordest 2, which will be prospective to enroll more patients and to study accurately this previous topic. And of course, starting from today, we are going to organize a Rising Star in Cancer Research Awards, Best Article Ovarian Cancer Award to encourage young scientists to do research on ovarian cancer, and also to provide more meta-research internships for our young oncologists so they can go further in their projects on ovarian cancer. And of course, this was just a summary. I am not someone who like perfection, because really we can never reach it, but I try to do with what I had in my head. And I have some personal perspectives before ending this presentation to share with you. In fact, during this project, I've never received any public or private funding to build my project. All activities were self-funded based on my small salary. And you know, we are all going to die, and we should not leave any money in the bank. So I really believe in this. If I have some money, then I need to invest it in research, because our patients deserve and merit more research on this aggressive cancer. And sometimes, you know, small amounts we can do a lot of cancer research by developing individual initiatives with what we have in our hands. So this was really a personal and an individual project. When I discovered that this is a neglected cancer, then I tried to do my best with what I had in. And before ending the presentation, I know that I took more time. In fact, this slide is from 2015, when I was a medical student and I was doing workshops for young scientists, and I was talking them about the aortic Congress to be held in Morocco, in Marrakesh, and they said, you need to submit something to the aortic. So I knew about the aortic earlier in my medical studies when I was a student. I think the aortic now need to invest more in attracting more medical students to the field of research and oncology, so we can fight against this shortage of clinicians in low-income countries. My acknowledgement. Sorry, I would like to thank all our TIC leaders for this opportunity, my collaborators, and I invite you to join us in our city in northeast of Morocco. This is my contact if you want to contact me for further collaboration. And That's it. Thank you so much. And I will be very happy to take all the questions.
Thank you very much, Dr. Khalid, for that wonderful presentation, very inspiring. I think we have a lot to learn from you. You do deserve some funding based on what you presented. So, but it would be good to learn from how you managed to do all that without any funding. Any quick comments from anybody? There are a lot of comments in the chat box, many about how you've done so well. Congratulations, and we need to learn from you. Anything else that we need to?
Thank you so
Any
much
quick
first
comment?
Thank you so much first for watching my presentation, and apologies if it was long. In fact, I think each African scientist, including young oncologists, should develop something with what they have in their hands. I think even publishing a case report on a rare ovarian cancer tumor is something very interesting. So if all of us, for example, as young scientists, do something, small projects, even very, very small projects, then I think when adding all of these small things, I think Africa would be great. To be honest, I have never received any funding. So all my travel to participate in international congresses and also to collect data, do analysis, reporting, publishing was self-funded. Sometimes I receive, for example, travel grants from ISMO, but it was not really funding. So I think we have opportunities to invest. I know that there are nice organizations outside Africa that can help, the ISMO, the ASCO. Also, the AWATIC is doing great with their collaboration with the American Association of Cancer Research to provide fellowships and grants and research funding. But I think if we find the best topic that do not really need any funding, just good training in meta-research, in evidence-based medicine and research methodology, I think we can go further and do our best. The day, as I said in the introduction of my presentation, the day I discovered that ovarian cancer is neglected in Morocco, I said, okay, this should be my research topic. I need to do something. So I think we need to develop this love to what we are doing. And I know that African scientists, they can do, we have good brands in Africa, and I think we can go further and do things. And I will be very happy to take some particular questions on particular parts of my project.
Thank you very much, Dr. Khalid.
If I could just say a few words. This is Chris Williams speaking from Canada, and I would really like to congratulate Dr. El-Bairi for this excellent presentation. I see this as a great opportunity for AOTIC to actually begin to see the essence of international and multinational studies, to be able to actually focus on the problems of cancer in Africa. Ovarian cancer is a very difficult disease all over the world. And to listen to somebody like Dr. El-Bairi with these very original findings, I think that AOTIC should take an opportunity of projecting itself through somebody like this. By organizing multinational African collaborative studies to validate the very, very important observations that he has presented. It may turn out that they are actually valid, but it has to be validated. And if it is so, it could have actually a global impact in the management of ovarian cancer. Ovarian cancer is a top disease globally, not only in Africa, not only neglected in Africa, it's neglected everywhere, because this is a kind of a silent killer of women all over the world. Now, AOTIC has a very great opportunity to be able to make an impact globally through the presentation that Dr. El-Bairi has just made. So I would suggest that the president And we should begin. Luckily, the president is a gynecological oncologist. It should begin to actually make an organization an arrangement for this to be validated through an international effort under the auspices of AOTIC. Thank you.
Yeah, I totally agree with that. I really appreciate your comments. We cannot go further without international collaboration with our African colleagues. So yeah, this should be something to be done in the near future. I know that I cannot really defend my biomarkers widely because this needs validation. Yes, I totally agree. And I think external validation can be done with some African colleagues. And in this perspective, I hope that our team can provide some contacts so I can share my methodology and research project protocol with my friends from Africa, and then we can do great things. I know that, as I said, external validation is required, and I think the best place to do validation is a similar setting like all African countries. So thanks again, and hopefully maybe in the next upcoming month, we can organize something like that as a webinar to go further. And also maybe we can organize a best ovarian cancer research award for all African young oncologists. I do this for a Moroccan setting, and it works to encourage people to work on ovarian cancer. And I think we can do this globally for all African colleagues. Thank you.
Thank you very much, Dr. Khalid. Very, very inspiring. If you could please, for those who might not have got it, your contact was at the end of your presentation, but it skipped through fast. If you can post your contact in the chat, and then we'll move on to the next presentation. Our next presentation.
Sorry, I have a question. I've been waiting in line. I don't know if you noticed.
Oh.
Sorry, this is Richard Naidu here I'm from the University of Cape Town, and I'm actually in the Netherlands right now. So I wanted to ask, thank you first for your presentation, Khalid. I know that, biomarker research has focused a lot on molecular diagnostics and molecular markers. Are you or anyone in the organization looking at these, since these are so pivotal in identifying and new and early markers for diagnostics or for therapeutic purposes? Thanks.
Yeah, this is really a great question. In fact, because ovarian cancer is neglected, and we neglect more early screening. So I know that there are few initiatives to develop biomarkers for early screening widely, but unfortunately, it's not comparable to predicting outcomes. So to be honest, I don't work on early detection of ovarian cancer, and I don't know anyone in Morocco working on that, unfortunately. And it's a great topic because we didn't make any progress in this particular field of ovarian cancer. Unfortunately, even in the United States, we still use very old approaches to do screening, and ovarian cancer is still unfortunately diagnosed at advanced stages because of various factors. So for our setting, unfortunately, we do not do this, but I think we can go further and work together on this.
I really think that going forward, the organization needs to look at the implementation of this very, very important facet of research, because it's moving in at an enormous pace in the rest of the world. It is moving in South Africa also, definitely in the private sector, but it's something for the organization to look at. I'll be happy to chat to you offline or on an email, so maybe we could take it from there. Thank you.
Thank you. Remember to post your address. Our next speaker is Dr. Wafa. She's an assistant professor in the Department of Obs and Gyn at the Aga Khan University Hospital in Kenya. She's involved in the training and supervision of postgraduate students, and she's a member of the African Cancer Coalition and ESGO. She is involved in the harmonized NCCN guidelines and is a technical advisor to the Kenyan National Cancer Treatment Protocols with the objective to reduce mortality related to gynae cancers in Kenya. Dr. Khadija, please go ahead. You're welcome.
Good afternoon and good morning from wherever you are. And thank you so much for joining this outtake session. I think I've been so inspired by just listening to Khaled. Honestly, excellent presentation. And thank you for coming on. Vanna and Rahel, thank you for discussing the guidelines. I'm actually going to take a different approach, and I'm discussing what does surgery mean to us in Africa, and what difference can we make in our setting. So I think I'm going to go over some of the slides Vanna had gone over and discuss some things Rahel had discussed, and then go over what my thought would be for the way forward for us as a continent. So, I mean, of course, we all know ovarian cancer. Originally, most of the ovarian cancer arises from the epithelial ovarian cancer is what is detrimental and killing to women, right? Because you can get germ cell, sex cord stroma, but what we really what is the killer in all of this is the high-grade squamous cell carcinomas. And I mean, unfortunately, in our continent, nobody knows in terms of prevalence, which one do people subclassify, do our pathologists actually give us where the origin of the disease is. So this was an interesting publication which looked at the incidence of cancer, and they looked at 12 countries, and they looked at how is it increasing over time? And if we do notice, fertility is changing in our country. Age for women delivering their babies is later, and there's a shift in cancer. Previously, we were only discussing cervix, breast, but I think we have to consider where we are at for ovarian cancer. And this trend of increase, actually, we should improve care by when we notice this kind of changing trends. So the clinical presentation, basically, which we all know, is that either you acutely come to hospital, ascites, pleural effusion, a new onset of an embolus or bowel obstruction. And unfortunately, in our continent, a woman with a bowel obstruction will appear in a peripheral hospital. Somebody will be left like, oh, she has a bowel obstruction. They do a huge midline incision. Oh my God, it's a tumor. Close her up. She's sent down to the ward. Unfortunately, the patient dies, and moving on swiftly. So no histology is taken. Nothing is done for majority of these women. Incidentally, sometimes you can find it in a younger woman, a pelvic mass, or you can find it intraoperatively for something unrelated to why she came, or sometimes even in my setting, we find on PAPs, you can find abnormal cells, right? So given the very varied presentation of ovarian cancer, it's like a silent disease because you never know what you have. So in our setting, for example, people come with diarrhea, they keep getting metronidazole repeatedly, and elderly women come with very distended bellies, and by the time somebody thinks, it could be ovarian cancer, it could be late for this woman. So this is from a CT from one of my patients. If you look at this CT scan done, just massive ascites, right? Like bowel is all squished into one area. This woman is just in significant distress because of the amount of fluid in her belly. And if you ask them, how come you didn't come? They never tell you that they had any symptoms, right? So this is why it's known as a silent killer. So diagnosis-wise, you have to do a good history and physical for all of us attending the meeting. In terms of imaging, you use what is available to you, right? Depending on your resources, but the bare minimum, I mean, an ultrasound, CT, MR, pelvis and chest imaging. I mean, some people are starting to do PETs in some countries in Africa, and I have patients who keep asking me, should I do a PET? And I'm always left like, it's an overkill to over-investigate. And then, of course, serum biomarkers, cytology, and biopsies. Because remember, gynae malignancies sometimes are secondary due to other things. So sometimes people get pumped with medication. And interestingly, for us in our continent, one of the things is TB, right? Because women who have abdominal TB have or mental disease, they have ascites, they have the same features like on ovarian malignancy. So without a biopsy, as a clinician, you should never accept to treat or operate on a patient, right? And then patients, I've put this in asterisks because this is our ideal. All patients should have a genetics evaluation. So in terms of surgery in this continent, I think the most important thing is experience, and the surgical expertise is the most important thing, right? And one of the things I look at is there was an interesting ESGO presentation I once attended, and the thing is you have to do the most difficult area first, because most people put a big midline incision and then start with the bottom end. Any gynecologist can always do a hysterectomy, right? But that's not why we are here. The upper abdomen is the most important part. If you're not able to remove the upper omentum, the peritoneal stripping, then there's no point of doing the bottom ends. And the reason is you're going to get suboptimal surgical care. So this is just a quick surgical steps. This is available on the NCCN harmonized guidelines on most surgical textbooks in terms of what are the steps for you to do when you're doing good surgical techniques for ovarian cancer. So, and when you're considering cytoreductive surgery, the question is this operable or resectability? These are the things to consider. And you have to have a clear thought process in terms of, as Vanna once said, people just open a patient, pick things out, and then they're done. So it's not about picking things out of a patient. It's actually the impact of what you leave inside the patient in terms of prognosis. And the goal of any surgical procedure should be a maximal cytoreduction. So operability is you look at the patient, frailty. Remember, our patients could have poor performance status, they're elderly, have medical comorbidities, and this has an impact in terms of, are you able to operate on this patient, yes or no? And then resectability, you have to look at the images. Like the image I showed you, tons of ascites, omental adhesions, extending to the spleen, suprarenal. If you can't cut it out, then don't open the patient, right? Because these are the patients who, by the time you want to then give them neoadjuvant or some type of chemo to bring things down, it's a wasted opportunity. In good settings, they do consider diagnostic laparoscopies before you kind of say this is operable or inoperable. Because a diagnostic laparoscopy is just putting in a small camera, distending, looking, is this doable or not? And I kind of like this because it avoids futile laparotomies. There's the Fagotti score, which was developed by Anna Fagotti and team from Italy, which looked at, I mean, if you have a score more than 8, then you're going to be offering a patient a suboptimal cytoreduction. And these are available online. So giving us that kind of background, where do we go on from here in terms of in our low resource settings, right? Vanna had talked about this previous article, which was published in collaboration with many African oncologists in terms of how do we assess a woman. So I just looked at the surgical aspect of this in terms of what is the most optimal surgery for women. And the optimal care is good surgery in one sentence. I mean, it's just a good surgical technique. And the benefit of surgery is diminished when you have suboptimal cytoreduction. So this is what was discussed in this article, where you have basic, limited, or enhanced. And I'm just going to, circle on enhanced in terms of surgery. So a good surgical setup should have a good operating room, a trained gynecologist, or a good obstetrician who works with a good surgeon who collaborate together to manage these patients together, and good post-operative care. So you have to manage expectations, right? So the extent of surgery has to be completed, and you have to have a facility that you're able to manage the post-operative complications. And then in our setting, you have to have this discussion about plus or minus bowel resection. So when you're consenting these patients, they should actually have this discussion. Remember, African people don't like stomas. There's this thing of the shame, they have this fear of the odor of feculent material within the community. Women want to go to the church, they want to meet in a communal setup. So we have to be operating in the context of our people, not just grabbing a guideline from out there and saying this is going to be done. So how do we improve? This is the second part of my talk in terms of how do we improve / standardize care in this continent. And ESGO has developed this excellent quality indicators. And the reason I really like this quality indicator is that if you look at this, it's 10 quality indicators, and then you group them into different groups. And I think as individuals or as surgeons operating on women who suffer from ovarian cancer, you look at yourself as an individual. how excellent are you as an individual? Like I'm a trained gynae oncologist. If I open up a patient, what is my personal rate of completion of surgical staging? And what is my rate of primary debulking surgery? So do I choose my patients well? So good patient selection, not futile laparotomies, because everybody can open an abdomen. But the question is, what have you done for the patient? And then looking at the center that you're working in, how many surgeries are done every year, and who does the surgeries, right? And then the surgeries, is it a gynae oncologist, is it a general obstetrician, and does the center you're working in participate in clinical trials, and do you have MDTs? And the reason is having an MDT is where there's a gynae oncologist, a medical oncologist, a radiologist with an interest in cancer will sit together, look at the images, discuss pros and cons, go over the patient, and then decide, is this doable or not doable? In my center, for example, I have a lovely colleague who we work together, a very good radiologist, and we always have this joke, are you blessing me to operate or not? And the reason is in surgical care, we don't work in silos. So you have to have a team that's dedicated to working with you, and also working with good colleagues who are good surgeons who can come in with you and to tackle the more difficult areas. I trained in bowel procedures, but at the center that I work in, I have to get a general surgeon to do my bowel procedures with me. And that's not compromising my profession as a gynae oncologist. It is just improving the care to the woman on the table. And then good preoperative workup. And that is the essence in terms of good surgical technique requires you to have excellent imaging pre-op, good workup, optimizing the patient, like a diabetic patient, optimizing their medication, the hypertensive, good pre-op care. And then, of course, post-operative management, right? The pre-op, intra and post-operative management, and then operative reports and pathology. And I want to highlight pathology because sometimes in our setting, as a surgeon, you might do an excellent procedure, but then you have poor pathology. That doesn't help the patient because then you're not able to give the patient adjuvant treatment depending on what you have. And I'm going to skip a bit from ovarian cancer, but for example, in radical cervical procedures, if somebody does a radical hysterectomy and the pathologist is not giving you what you need to know, then you end up wondering, am I giving this patient adjuvant or not adjuvant treatment? So that's why you have to collaborate to get good care for your patients. And then prospective reporting. So this ESGO guideline is free, and it's actually, if you look at a quality indicator for us in Africa, the question is, we don't have a center of excellence in this continent. For example, South Africa has excellent surgeons, excellent centers where they operate and collaborate. Other countries, Nigeria, Ghana, Kenya does. But the question is, if we had 1 or 2 centers within this continent where excellent surgeries, and we would pool our patients, then that would increase surgical expertise, good training for our fellows in training, and have a larger bulk for patients, and excellent quality indicators would be developed from such an area. So surgical reporting, where I trained, for example, reporting was actually done as a synoptic report. And the beauty of a synoptic report is that you tick a tick box. Was this done? Was this done? Was this done? And this helps you in terms of what was done for the patient, what exactly happened to the patient in comparison to dictated reports. When you have a dictated report, it's like you're telling a story, right? A midline laparotomy patient opened, and that doesn't give you exactly what was done. And in terms of quality, synoptic reporting would actually have a good indication in terms of quality indicators. So this article was published, it's actually not, it's out for publication by colleagues from Canada. And the good thing is that you collect more data when you use synoptic reports. So for us in an African setting, having standardized quality indicators in terms of what we are doing, and also development or borrowing synoptic reports from other centers and using them in our areas to actually see what was done. And this is also important for areas where there's training. Residents in training would really benefit, because then every time you do exactly the same thing repeatedly. So not doing dash procedure for Miss X and dash for Miss W, doing the same thing every time. I'm going to switch gears a bit to primary surgery versus neoadjuvant treatment. And the reason this comes a lot is that in Africa, people have this assumption that A, patients can't afford your surgical technique. B, the surgeon is not competent enough to operate. So the compromise is always to offer neoadjuvant chemo with the assumption that it's always better for our patients. And if you look at a primary cytoreduction, this is the way to go. A primary cytoreduction, if you choose your patients well, in terms of, and if you offer radical primary cytoreduction, your survival is better, right? When you leave no gross disease. And this paper compared neoadjuvant for newly diagnosed advanced for newly diagnosed and also advanced ovarian cancer. So this is a simple table to look at in terms of what is the workup that you need to do for the patient. Does the patient have a high risk peri-op morbidity, morbidly obese, multiple comorbidities, massive ascites, like 2/3 of the image is full of fluid, rosetting of the mesentery. Basically, you look at a patient or you look at the images and you're left like, I'm not able to do this, then the standard would be offer neoadjuvant chemo. If you say no to yourself as an operating surgeon, the question you ask yourself is that, am I able to do this perfectly well? Of course, not perfectly, but to the best of your ability with that patient. If you say no, then the patient would again benefit from neoadjuvant chemo. And if you say yes, then I mean, if you say no, you'd offer them either neoadjuvant or primary cytoreduction. If you say yes, then offer them neoadjuvant chemo. This kind of helps you put your patient into perspective at that point of seeing them. And which patient do you select for what? If you look at our continent, frailty, elderly patients in this country, a 60-year-old in Africa and a 60-year-old in the US, for example, are definitely not the same. A 60-year-old in this continent has gone through more, has suffered more, has maybe more medical comorbidities, so might not do as well as a 60-year-old in another continent. Radiologically, I'm just repeating myself here, looking at, I look at bowel adhesions, especially small bowel and rosetting of the mesentery. That for me is the no-no in touching a patient. And then looking at peri-op morbidity, if you have a poor nutritional status, albumin levels, massive ascites, a newly diagnosed VTE, and stage of the disease would actually indicate should you or should you not. So if we look at the trials which looked at neoadjuvant versus primary cytoreduction, a lot of people fault the Vargotti trial and the Chorus trial, but in terms of their patient selection and the surgery they offered, in terms of the timing, the length of surgical procedures. But if you look at both of them, I've circled that the survival, overall survival, is somewhat similar. And Cochrane looked at a very detailed review in terms of should you offer primary surgery or neoadjuvant in a newly diagnosed ovarian cancer. And the answer that comes out of these trials is that basically it's almost similar if you choose your patient correctly. And the interesting thing is that in this continent, for example, neoadjuvant chemo, even in my setting in Nairobi, is never given as a standard. You'll see somebody, a medical oncologist would send a patient, they've been giving neoadjuvant for 6 cycles, and then they say, now operate, right? So standardizing care in our continent, saying, if you're offering neoadjuvant, this is the standard of care, this is the drugs you should give, and then your surgery should be done after such an interval. And then when we operate on a patient, when you have the pathologist receive your specimen, this pathologist has to tell you what is your chemotherapy response score. And we have a gynae pathologist, fortunately, in where I work, because this is the information that you want, not the debulking status, because you actually want to know how much tumor is left after the neoadjuvant chemo, and is it viable or non-viable tumor in terms of planning the way forward for your patient. As a summary of my previous slides, it was a non-inferior overall survival and progression-free survival when you compare both neoadjuvant and primary cytoreduction. But note, neoadjuvant would be better for the stage 4s, right? Not the stage 3Cs and below. If you have the stage 4 frail patient, a lot of disease, then just offer them neoadjuvant, better than putting a knife on an open and close. I really dislike open and close procedures. This trial eventually in 2024 will tell us in terms of what should be the way forward for us to consider patients for primary cytoreduction or neoadjuvant with the long-term overall survival data, because this would cover the limitations from the previous Vagoti trial and the Chorus trial. And lastly, I think this is something which I'm really passionate about, is that ERAS. I wish I would have collaborators from this setting in terms of establishing ERAS in our continent, where, you know, when I first came back, the question is like, you have a post-op patient and no mobilization, they lie down in bed, catheter doesn't come out. This has an effect into your surgical care. So consideration as if there are any surgeons on the webinar today in terms of good ERAS, so that you have good care for your patients. And with that, I come to a conclusion, and thank you so much for listening.
Thank you very much, Khadija. Very nice presentation, a lot of good insights. Any comments from the team? Appropriate surgery is the bedrock of the care of ovarian cancer, from Christopher Williams, and without it, systemic measures are meaningless. A lot of other comments with regards to how insightful your presentation is. Anything else? Any burning questions? We are running out of time, but we've been informed that we could run over just a little bit. All the discussions have been very insightful, clearly a much needed topic to have had. Any other questions? If not, I think we can move to the next session. So our next speaker is Frances Reed, and she's going to talk about the Every Woman global study on ovarian cancer. She is the program director for the World Ovarian Cancer Coalition, and she has worked with women who have had ovarian cancer since 2003, advocating for improvements in survival and quality of life. Joining the coalition in 2017, she led the development of the Every Woman study and is the principal investigator for the LMIC edition. She's previously worked in many UK charities, developed the Target Ovarian Cancer Pathfinder study, which led to the formation of the all-party parliamentary group on ovarian cancer, the development of new national guidelines and award-winning professional development tools for general practitioners. She was involved directly with ovarian cancer guideline and quality standard development through the National Institute for Health and Clinical Excellence. She has prior work working with women who have ovarian cancer and has had worked with the British Broadcasting Corporation as a radio programmer, maker, and editor. Frances Reed, you're welcome.
Thank you very much, and thank you everybody at Aortic for this wonderful opportunity to talk about the Every Woman Study Low and Middle Income Edition. I'll try and race through my slides. I'll be joined by our Kenyan lead as well, Dr. Afrin Fatima Shafi, a little later on. So I'll give you a little bit of background about us. The World Ovarian Cancer Coalition is a not-for-profit, and it is a membership organisation. We have well over 200 members now from over 50 countries. Predominantly, it's split between organisations involved in ovarian cancer, organisations involved in gynae cancer, and then pan-cancer groups. A lot of them are patient organisations. Some may fund research, some do advocacy, some raise awareness, a real mixture of organisations, some really small, run by volunteers, other much larger ones. And our mission is to empower the global ovarian cancer community through knowledge, collaboration and action, and to see a world where every woman with ovarian cancer has the best chance of survival and the best quality of life, no matter where she lives. So you'll remember from earlier this afternoon, cervical cancer, yes, the biggest issue in low and middle income countries in terms of gynae cancers, but with initiatives such as the Global Elimination Strategy, those numbers which you see before you will be coming down. Ovarian cancer has significant incidence and mortality in low and middle income countries. And as you've heard again this afternoon, it's a very challenging disease. 5-year survival is below 50%, even in high-income countries. As we go forward, Globocan have predicted a worldwide increase of 36.6% in incidence and nearly 50% in mortality by the year 2040. And when you look at where those increases are likely to be biggest, it is in developing countries, and Africa is due to see an 86.9% increase in incidence in ovarian cancer by the year 2040. So as time moves forward and cervical cancer becomes less of an issue and less of a challenge, the challenges of ovarian cancer will be there and will be increasing. So we really believe it's time to do something now. As we mentioned earlier, standard treatments have been around for decades. They are all on the WHO list of essential medicines. That does not mean that they are always available or affordable or accessible in countries, but they are on that list. And they can bring better quality of life and good results. If you get women in as soon as possible, there can be really good improvements and women can have a better quality of life. Family history is really important. We talked there was a bit earlier about PARP inhibitors and their advent and what a game changer they are, but family history is really important for prevention and reduction in risk. Cases linked to breast cancer, prostate cancer, pancreatic cancer, and with Lynch syndrome, things like endometrial cancer and bowel cancer. So we really mustn't miss opportunities. Up to 20% of women have BRCA-positive tumours, germline or somatic mutations. That does make them very responsive to PARP inhibitors, but that means there are a lot of cases that could be prevented in the future. As I mentioned, accessibility and affordability are key. So the Every Woman study, this was set up, we developed it in 2017 and ran it for the first time in 2018. It's about patient experience. What happened to women? What is important to women? We had 1,531 women from 44 countries. The results were published in the IJGC. The globe shows you the larger the text of the name of the country, the more respondents we had. And for these countries, we were able to show some quite significant differences. There are a common set of problems, but each country had a different mix of problems, and no one country was without significant issues. So time to diagnosis in some countries was up to 3 or 4 months longer than in others. But in the countries that did well in time to diagnosis, they did very poorly in things like access to genetic testing or access to good quality surgery. So there's a real opportunity to look and see what happens in different places and to try and see what could be done in any country's situation to improve the situation there. The caveat for the study was that 95% of respondents, despite it being available in 15 languages, came from high-income countries. So there was a real data gap, okay? 70% of women with ovarian cancer in the world live in low and middle income countries. And that's why it's really important to have good data that can be worked on. We hope with the Every Woman study that national and larger regional data on a range of key patient experiences and some clinical data too will bring forth and highlight particular issues for particular countries, and that can be used to advocate for national and system change. We'll be able to provide comparability between countries, between the overall group, between income status, between resource status, even at the centres that are involved in the study. Sorry, a bit croaky today. And we also are looking for opportunities where women and clinicians come together and advocate. We've already seen the creation of Ovarian Cancer Malaysia, for example, as a direct response to the study. These are the areas of questioning. In things like questions about treatments, it's about what's important for the woman. What are the long-term side effects she's finding hard? What is her decision-making process about having treatment? What have been the financial implications of treatment and so on? So the questions are really quite wide-ranging. So We have, I think I've jumped forward an extra slide. Yep, we have 24 countries involved in the low and middle income edition study as of August 2022, split geographically and between income levels. And I'm delighted that I know there are quite a few people on this call who are involved in the study in some way as country leads or site leads, which is brilliant. We have the survey available in 31 languages, and local clinical teams who are rolling out the surveys in the study choose how women can participate depending on the women's needs and the needs of the hospital team as well. So it is available in a secure email link, a secure WhatsApp link. It can be done on paper, a paper survey, and many centres are offering women the chance to have somebody sit with them and go through the survey questions themselves. It takes between half an hour and an hour to complete, depending on a number of different factors. These are the countries, the African countries that are participating. So we've got really good African representation and languages. You'll see the number of centres, hospital centres that treat women with ovarian cancer vary quite widely between the countries. Sometimes that's to do with the infrastructure. You know, in Zambia, the Cancer Diseases Hospital and the women and newborns, but they are the ones who do the surgery and the chemo. Those are the only centres that treat women with ovarian cancer. So we are collecting data. We have got a third of countries now entering data onto our REDCap system. We've got, I know at least 2 countries are collecting on paper and about to move forward with significant numbers onto REDCap. We've got another third of countries ready to start data collection. And for some, we're still trying to sort out some issues with translations, some questions about ethics. A couple of countries, progress seems to have stalled, but we will work very hard to make sure that we can move them forward. So we already have data, when I did this set of slides last week, on around 361 women. That's gone up already since then. And I'm just going to give you a tiny flavour of some of the things that we'll are seeing already. These are not statistically significant, they're just observational, and it really depends on which centres and which countries are submitting data at the moment. So data you're going to see comes from Argentina, Brazil, Peru, Kazakhstan, Malaysia, Vietnam, Kenya, and we've started actually with Nigeria as well. So, but these are the sorts of things that we'll be able to look at. We'll be looking at the types of ovarian cancer. I know already, looking behind the scenes, that granulosa, for example, is significantly more common in Kenya than it is in some of the other countries that have submitted data. So we'll have information like this. We'll have information about neoadjuvant chemotherapy, drug availability, genetic testing, all those sorts of things, as well as things that are really vital for the women. Around 2/3 are currently late stage diagnosis, stage 3 or 4. That seems fairly consistent at the moment. But here you begin to see some differences coming in, and these are percentages here. So 60% of the women who have completed the survey so far have been employed or were employed at the time of diagnosis. But here we can look at things like the proportion of women who live more than 5 hours away from a hospital. Kenya, the bright pink part, is standing out considerably here. But I know, for example, say in Argentina, the centres we have involved at the moment are in the very big urban areas. So in the south of Argentina, we have a centre that's due to be involved where most women will travel a couple of days to be seen. So this data will all begin to change, but it will give an individual country some really core statistics. They have to achieve a minimum sample, and it will provide some levels of comparability through the analysis. So here, highest level of education being primary or no formal education, very high proportion in our group so far in Kenya, differing in other countries. Household income below average for the country. We look at some of the things to do with ovarian cancer. Again, Kenya standing out for never having heard of ovarian cancer. This is an interesting one. The proportion of women in Kenya who first visited an alternative healthcare practitioner about their symptoms. And one thing it's important to note down here, out of all our group, and this is, we showed this actually in our last study, 90% of women do have symptoms that are associated with ovarian cancer. Only 10% do not have any symptoms whatsoever. And that in our previous study was shown to be irrespective of stage or type of ovarian cancer. So there are opportunities to improve the time to diagnosis and so on. And this will emerge through the study. We looked at, finances, and interestingly, many women say their finances have been affected to some extent, but you'll see this figure here, 29.4% their household income has dropped below what they need to live on as a result of their diagnosis of ovarian cancer. Financial toxicity is very real. Interestingly, just a fifth of women would not be interested in taking part in a clinical trial. 3/4 of women say their government could definitely do more to help women. We ask women about their priorities. Screening is coming out on top at the moment. This is a really interesting one. The next most common response is ensuring women have free access to diagnostics. A lot of the time we talk about free access to treatments, but unless women actually get there, they won't get the offer of any treatments either. We're collecting data until the end of June 2023 in some of our lowest income settings that may well extend by 3 months to make sure that they can achieve their minimum sample size. And we're beginning to seek advocates in the different countries to help with publicity and communications work, and we're beginning to look at the publication opportunities. We will be working as a global group, we will work at a regional level, and we will be involving our country leads and encouraging our country leads also to be publishing information. And we couldn't do this work without them, no way. That and the support of IGCS. This is a joint project between the Coalition and IGCS. And, we're thrilled to have them involved on this. And that's all from me. I want to introduce you now to Dr. Afrin Fatima Shafi. She is our Kenyan lead, and she's from Moi Teaching Referral Hospital in Kenya. And I wanted to ask her to share some of her experiences. So data collection is, we've got quite a few women responding, well over 40 now, I think, in Kenya. So Afrin, you're in the midst of doing it. I would like to hear from you about what's been easier and what's been a bit harder than you expected.
Good morning and good afternoon, everyone. Thank you so much, Francis. It's been wonderful participating in the study, and we've looking at this data, we've seen a lot of things that we previously knew, but now we get numbers. So one of the things that has been easier than expected is the consenting process, actually. We are really amazed that a lot of women are consenting to participate in the study, considering that most of these women come from very far away places. They have to wait in queues to get the chemotherapy. So we weren't expecting a very good response, but surprisingly, we are. Almost all the women we approach consent to participate in the study, and they're willing to talk to us. However, some of the challenges that we are currently encountering are that when the women are going through the questionnaires, the data collection tools, they get very emotional, and some of those questions sort of unearth certain feelings they had. So they tend to break down, and they want a long time. They want to talk about the condition. And let me give you an example. So I had a woman who came in, and she was being treated for recurrent ovarian cancer. She felt that she was a burden to her family because her mother also had colorectal PA. So even the mother needed treatment. So now the money in the family is not enough. So she felt like she was being a great burden to the family. So this is some of the things we are finding very challenging. They need a lot of time. They want more information about the disease, and they want hope, basically. In addition to that, some of the women expect some sort of financial support from us, So it gets a bit challenging. These are some things we want to see how we can work on them and mitigate these things. Yeah.
And in terms, I mean, that's really interesting. It is, women are very keen in our experience to share their experiences. And it is, I think, challenging trying to manage what comes up along the way. We are encouraging the countries that are involved to have been in touch with and recommend NGOs in their country who perhaps can provide financial support or can provide some counselling services. But that really depends on the country and the situation. But in terms of the process of data management, what have you also learned?
So in terms of data management, one of the main challenges in our situation is that we have to print these data collection tools, and then we then need to transfer them to the electronic database. So that rather takes up a lot of time. But otherwise, at least we have the whole data from from both our sites on the electronic database. So at least we can have a good look at them collectively. Otherwise, as such, we've been okay with the data management so far.
Yeah. And my last question to you, because I think you talked about your initial thoughts, but the process of participating in the study and seeing the sample data coming through, is it making you think about what comes next? And if so, what comes to mind?
Absolutely. When we look at this data, we see a lot of things. So some of the things that we would like to hopefully, after we've got the data, would like to increase training. When I say that we need to increase training, we need to educate the lower cutters to recognize the disease at an early stage and make the earlier appropriate referrals. In addition to that, of course, training is very important. We need to train more gyne-oncologists, surgical oncologists, medical oncologists, pathologists. The other thing is we need to scale up on advocacy. We need to give information to the women. You know, we are noticing, and when we look at our data, we're seeing that women don't know about the disease. So we need to inform them basically. So that this will include better public education through either TVs, radio. Radio is a means which is accessible to everyone, even in the women in the peripheral. In the very interiors or in the very rural areas has at least access to the radios, or when they come to the hospitals, at least they get regular talks and they're informed about the condition. The other thing is establishing survivorship groups. So we need to do this because we are noticing that women don't have people to talk to. When they come, they don't know. Most of the women have been saying that one of the main things is if they had someone to talk to, they would feel better. So I think we need to form survivorship groups so at least these women can talk to each other, and we can also counsel them and give them the necessary care post treatment. And we need to include policymakers and stakeholders, both in the public and private sectors, to actually make ovarian cancer a priority and make cancer treatment accessible to everyone, basically. Lastly, of course, we know that the cancer burden in low middle income countries is very high. However, we don't have access to a lot of drugs. So we need to get included in clinical trials, so through which at least we can get access to certain drugs, which I think everyone has been talking about, the PARP inhibitors or drugs such as bevacizumab. So once we have access, we are included in these clinical trials, we would get access to these drugs. We would be able to access these drugs. Yes.
Thank you, Afrin. And Afrin, as like all our country leads, has also undertaken video interviews, and there will be further survey work so that we'll give each country a sort of country report, and the information that she's provided helps us sort of put in a context, both in terms of local and sort of global findings. So thank you everybody for your interest. Thank you to Aortic as well, who have been helpful in helping us think through some of the issues and problems that we've encountered on the way. And thank you for this opportunity.
Thank you, Francis and Nifa, for Afrin, for your presentations. Are any countries still able to join the study, Francis? Maybe they can get in touch with you. Maybe you can put your email address in the chat box. Otherwise, I would like to invite Ceciltina Lorenzoni from Mozambique, who is the co-chair of African Organization for Research and Training, Education and Training Committee. And she's also a member of the Clinical Special Interest Group, as well as a representative of the Portuguese-speaking countries in Africa. Welcome, Ceciltina, for the closing of the meeting.
Thank you, Susan, and thank you everyone to participate at this session, where we approach the ovarian cancer, women's neglected in Africa. We're learning that we have many challenges in Africa, in the world, but specifically in Africa, in terms of education, training, and research. We're learning that we have also limitation in terms of diagnosis, in terms of surgical expertise, in terms of drugs access. Also, we are lack of studies in Africa, specifically in sub-Saharan in Africa. And I would like to, at this moment, congratulate Dr. Khalid, because he is one of the champions of studies here in Africa. Also, we have some challenge about the several guidelines in ovarian cancer, and but we must we can take this as an opportunity, because we can adopt these guidelines in our setting as a good practice to improve of quality of outcome. We have some opportunities also that does not need a lot of money. As the tumor borders, we can do the tumor borders in our country. We can try to work about to develop of clinical and translation research that could be affordable and can be changed in our practice. We can involve the youngest investigator, as we learning at the session that we can promote some award for young investigation in terms of ovarian cancer. And I would like also to emphasize that this is the big moment. This is a moment that we can apply also to IGCS, the countries that not have the gynecology surgical program. Mozambique is the one, I am from Mozambique, is the one that applied for this program since 4 years. And now we have our 3 first gynecology oncologists, and each 2 years we have the classes. And I would like to thank all for you the presentation made, especially Susan, which is the Education and Training President, Verna, Rael, Khalid, Katija, and Francis, and all the organizers that webinar, and also to all the participants. And we, as a member of Education and Training Committee, we will continue to promote this type of debate. So together with the other colleagues from Africa, Europe, Asia, America, and other continents, we can exchange experience in terms of cancer. And for closing, I would also like to address this day, which is the International Childhood Cancer Day. And thank you all for this webinar.